Hello there. I am joining you live at an unusual time for me. It's Wednesday afternoon. It is 2:30 my time, and I just had a bunch of questions come in, and just from the last week about functional seizures, and I really wanted to share what I know. So if we haven't met, my name is Julie Hirschberg. I am the owner, founder of Re+active Therapy and Wellness here in Los Angeles. And one of the reasons the questions on functional seizures came up this week was twofold. One, I'm hosting an interview on Friday with the amazing Katie Woodward, who is thriving with a functional neurologic disorder. And hello, Allison. Thanks for joining me. And she is going to share some of her story of being 3 months seizure free with us on Friday on our Facebook page, so you can join in. And when I announced that, I got people asking like, oh, can we talk about functional seizures? In addition, our Brain Bites group, which is a community of healthcare providers learning, growing together, particularly in our understanding of some of these complexities, complex cases. We were talking about functional seizures, and I got a lot of questions like, oh my gosh, what do we do? This is really challenging to manage. I don't know what to do. Oh, good. And Lily is here. Lily shot me a whole slew of questions. Thank you, Lily, to talk about functional seizures. Now, total disclaimer, I'm not a seizure doctor. I'm not a neurologist. I am a neuro PT, and I love working with people with neurologic disorders and functional neurologic disorders. So the term functional seizures has many iterations. Some people say dissociative seizures, psychogenic, non-epileptic seizures, or PNES is another common term. I like to use the word functional seizures. I think it keeps in line with the other functional disorders like functional movement disorders, functional tremor, functional dystonia, functional gait disorders that we see that are truly due to a functional disconnect in the brain, which is what we understand about functional seizures as well. They are one of the most common functional neurologic disorders. They're common in young people, in kids, and adults. And the questions that came in kind of started with the first thing like, is this a functional seizure or is it something else? So I have to thank Allison for this first question. Two was, as she said, how do I know it might be a functional seizure versus something else like a muscle spasm or twitching from another reason, like a metabolic reason or a medication and things like that. So great question. And here's where, like, me standing here on a video from a distance, I can't really tell you for sure that I know whether that is this or that, but I can tell you how they diagnose it. So one of the biggest things in distinguishing a functional seizure from an epileptic seizure is using an EEG and video EEG. In fact, they can get clear diagnosis like pretty readily through doing that. And particularly what they look for is somebody with a person who might have epilepsy, for example, have some characteristic spikes on an EEG. So most people that I have met who have functional seizures have indeed had an EEG. And that is important because the video EEG will show if there's electrical activity happening causing this seizure activity, or shows that they're not. So the person with a functional seizure doesn't have that electrical activity happening, driving some of their movements. So that is an important piece that I would highly recommend for people. Now, how might we know? So let's say you had the EEG. How do you know that this is a functional seizure versus a tremor or muscle spasms or things like that? And so that takes a little more diagnostic work, I would say, because there's so many causes for tremors and twitches, both physiologic, metabolic, medication induced, cardiovascular induced, that we would want a full workup of all of that to distinguish it from a potential seizure activity. But I will tell you, from a clinical diagnosis standpoint of the functional seizures, they're really looked at from particular clinical characteristics. So some things, and I've got a great article here for you too that looked at some of the autonomic pieces of functional seizures. And you know me, I love the autonomic nervous system. So they tend to be longer in duration, so greater than 90 seconds. Now, again, there's like a 10 to be, but it doesn't mean that every single one is like this, and that there are some epileptic seizures that also have some of these qualities. So a good neurologist is a big part of it. So longer duration, a fluctuating course, that I think that's really important, asynchronous movements, side to side, full body or head movements. Closed eyes is another big one, especially like hard closed eyes that you can't open up. A lot of people with epileptic seizures have their eyes open. And then memory of the event. So this gets me to one of the questions that Lily asked me too, is could there be confusion after the event? This is actually something that's commonly found in epileptic seizures, and not as common in the functional seizures. But again, there hasn't been a large study that said this particular piece of clinical evidence means you don't have a functional seizure or vice versa. So again, it's a whole picture analysis to understand what type of seizure activity that you're having. There are a few things that used to be thought only occur in an epileptic seizure, like incontinence, but it has been shown that those can occur in a functional seizure as well. And absolutely, I see that as well, because again, we're talking about connections, and if the connection has gone awry, we can lose control of our functions, including bowel and bladder. So those are big pieces. Now, I was looking at this really interesting article on the autonomic nervous system and epileptic versus functional seizures. And one of the pieces that was really interesting was heart rate variability. So heart rate variability tends to be lower in people with functional seizures versus epileptic seizures. We also see that the sympathetic activity, so this might be counterintuitive, at least in this one study, they found that the sympathetic activity was higher in epileptic seizures, and you actually see some excessive parasympathetic activity in a functional seizure. This is kind of where they've gotten the terminology of a dissociative seizure, is sometimes there is preceding it or part of the seizure a sense of dissociation. And if you talk to people who've had functional seizures, this is most definitely true, definitely true for the people that we've worked with. And this really brings me to some of the questions that you had, Lily, about, well, what do we do, particularly when it's a functional seizure and it's not happening in front of you? And if dissociation or a sense of being disconnected from the body is part of the seizure experience, one of the things that can be really important is regaining control and connection. And this is what I think physical therapists, occupational therapists, and psychologists do so well. This is why we do it in an integrated way in a group, is to bring the body, brain, mind talking to each other again. And I want to point out a couple of things. So I grabbed a couple screenshots. I've shared these before. This is a really lovely study from just last year of retraining and control therapy for pediatric functional seizures. And in this particular study, they did an approach of helping people regain control. So what I think of, Lily, in terms of PT is optimal all the way. Autonomy, restoring that person's locus of control of their body and their environment and their context. But in this particular study, all of the kiddos improved and had a remission of their functional seizures. I think that's really, really powerful. Yeah, and Lily asked a great question. Dissociation can mean if the person says, I feel like I'm out of my own body and I'm trying to get back in. Absolutely. Absolutely, that could be a dissociated symptom. And I will tell you too, I'm not an expert in dissociation, and I go to our psychology team a lot to help me understand what can be happening that leads to some of those symptoms. But yeah, this is a really great article that I wanted to share with you. But again, it's not saying, oh, we did optimal theory and this helped improve, but I take what are they looking at? And what they're looking at is the underlying pathophysiology with the functional seizure, which is this full loss of control, maybe totally outside of the body and not having control. And how can we help a person outside of that seizure state regain control and autonomy? And I will say, you know what? That's not a lot different than what we do with all people with neurologic disorders. Heck, all humans, but to set up our therapy in a way to rebuild that control. Now, I want to share a couple other resources here. So another great one was looking at some of the clinical differences between people with functional seizures and functional motor disorders, which I think as physical therapists and OTs, we tend to see a little bit more of. And in this article, it really hits on that key difference of some of those shut down dissociative symptoms. And one of the things we've started using is a screening tool. We use it as our whole team, PT, OT, psychology, which is called the Shut D, and it really looks at the body physiological shutdown symptoms that can occur. And we definitely see this more often in people that might be having functional seizures. Another key thing they found in this article was pain being one of the pieces that could be linked to having the functional seizures, which leads me to one of your other questions, was what brings them on? So pain, migraine, headaches were common ones. And then in that other article that I mentioned, autonomic triggers, so low heart rate variability, a dysregulated autonomic nervous system, so maybe going from a really like high fight or flight sympathetic response to a really low freeze shutdown type of response. And so those are things that we can screen. And what's like beautiful is that we can bring that right into treatment in befriending our bodies and understanding our bodies, providing tools to stay connected. And one of those ways, so let's see if I can get another picture for you here. As I pull it up here, one of the ways we could really do that is through some of our autonomic practices. So I'm going to pull this up here because I love our autonomic practices and feel so lucky to have a team that really embraces all of these. But we put together a few of these autonomic practices, and they're highly recommended in functional seizures, particularly the grounding practices, because they help in a dissociated state to reconnect to our bodies, to our senses. So Naoya recorded a really lovely sensory grounding practice. The breath practice, the guided imagery practices all have really been a part of some of those successful studies in functional seizures. So really great, because Allison's asking too, can you touch on common triggers, emotions, lights, noise, etc. So this is one of, I think, the biggest pieces that also gets to one of Lily's questions: how do we begin treatment? And I think treatment begins with a really good assessment. And Allison asked this question. A big part of our assessment is understanding that person's triggers. So you brought up really great questions because you are very insightful, Allison. And they can be from all sensory levels, right? So they could be visual triggers. They could be emotional triggers. It could be noise. It could be smells. It could be the state of your autonomic nervous system, which is why it's so important to measure that as well. Which, by the way, I forgot to mention this, in some of the common findings in functional seizures are actually like a syncope episode or a blacking out, passing out can also be a functional seizure. Now, again, we have good ways to check this autonomically and cardiovascularly as well to rule out whether that's actually a functional seizure. What's really interesting with the functional seizure is that it's not always that you're like at like this peak stress state at all. And in fact, you actually in an epileptic seizure tend to have a little higher heart rate, and in a functional seizure, it's not necessarily a heart rate. So this is one of those reasons why, like, I have these pet peeves about doctors or other providers saying, oh, you're just stressed. It's just anxiety. It's like, no, did you look at my heart rate? It's not. It's not just anything, right? So it's not always just that, like, you were in the middle of a stressful event and then had a functional seizure. But I will say one of the things that is really helpful in exploring the triggers is almost looking for the layers that might add up, like all of the sensory stimuli that might add up during the day. I think back to this great story that Katie shared in her first interview with us. She had a seizure on one of her first days walking across the floor. Well, you know, what was happening there? Fluorescent lights, the pattern on the floor, you know, likely many things leading up to that. What's so important in that I think in our PT/OT psychology treatment of this is what happens in after the seizure too from the healthcare professionals. You can imagine, and I can imagine this as a parent very much, witnessing this, like just full on freaking out about it, and being so concerned. I mean, this is a very high rate of ER visits and hospitalizations, which totally makes sense because this could be really scary without understanding it. But one of the things that Katie relayed to me in our interview, Chelsea did this initial eval, and Chelsea is amazing. And she was able to recognize, okay, this is one of your functional seizures. We see this all the time. What do you need in this moment? Like, here's a weighted blanket. Like, let's get through this together and really build up some safety and trust in that moment. And so, okay, really great questions here. Lily's asked, what should we advise when they're in the middle of the seizure? This is what we do in therapy. This is why I think it's really nice. Lily asked the question, like, well, what do we do? Because they look totally fine, in the midst of a therapy session, and then they have a seizure. Well, this is where you're building up a toolbox for them to stay connected to their breath, to their body, to their sensations. If you consider the functional seizure a disconnect and a dissociation, you're going to build up the person's toolbox for connection. And that's going to be different for everybody. So like a weighted blanket might have helped Katie. It might actually make it worse for somebody else. So you're going to explore those pieces together. Many of them are sensory. So think all sensory systems visually. So they may need lights out. They may need bright light, right? This is going to be very person specific. It might be hearing related. It might be smells. It might be sounds. It might be vestibular input. There's going to be so many different ways you can explore that with the person and help to really stay, that they then have the tools to stay connected. It's not your job to be there and calm down a seizure every time, right? Your job is to help that person discover those pieces within themselves. Great question, Lily. Can high blood pressure cause this too? What if it's, let's say the person's on high blood pressure meds and And to address the lifestyle factors, they can't exercise as well, greater intensity, because of that blood pressure medication. Yeah, so that would be another really important piece to explore with them, is to look at blood pressure being a potential trigger. And are there other ways that that person can connect and move and have an activity level that sustains their nervous system that maybe is not what we consider, I'm going to say, quote, exercise. But I do find that for most people I've worked with a functional seizure, it's been really helpful to do some exercise tolerance testing to know what their blood pressure or heart rate might be that might be triggering symptoms. And then we can gradually expose to higher and higher levels of activity and heart rate and blood pressure. So really, really great question. Allison asked you, have I seen hypoglycemia as a trigger? So I will say I've suspected that, but I don't test it in the moment always. But I've had other people test that, and certainly I have seen everything under the sun. But what the person's blood glucose level at the moment may be, what I have found is not it being like that one thing. I have to say it's been really hard in a lot of people to nail it down to one thing. Did they not eat as much that morning and they had low blood sugar, and they're in a certain phase of their menstrual cycle, and they didn't sleep last night, and the fluorescent lights were really too much, and then Julie came in with this big stripy sweater on. So it's like, okay, there was layers there, and we kind of need to peel them away. So I have seen it as like part of multiple layers. Now, I want to give a couple of other great resources here. Love this little article that came out from last year, Practical Review of F&D for the General Physician. It actually has a nice little nugget on functional seizures. I highly recommend it. I think we even sent it to a primary care physician this week. Like, let's educate the world. It's a really great review, and it has a section on functional seizures. And I want to give another one here. This one here. So I love John Stone's website, neurosymptoms.org. If you haven't been on it, it's phenomenal. He is in the UK, does a lot of advocacy and research in functional neurologic disorders. And this is directly from the neurosymptoms.org website and the page on functional seizures. And they're in this terminology, they're calling them dissociative seizures, but let's call them functional because I like that word better. But basically, this cycle of learning occurs so rapidly in our brain, we can't even control it. So this is not the person making a conscious choice to do this by any means. This is what can occur with a pattern. And this is actually why people with epileptic seizures can also develop functional seizures because of a pattern. So one thing I really love at the bottom of this, it says life stress in some, but not all patients. So again, this used to be thought of as a purely psychological issue, and it is not. Yes, might that person have a life stress? Yes, might they have anxiety? Yes, might there be things going on? Yes, but it's not the only thing. So there usually are some other sensory motor disconnects that are functional in nature. But for whatever reason, this person is in a state for neuroplasticity to go awry. They have this dissociative or functional seizure, which may come from a tendency to disassociate and not be connected to the body. I actually have this tendency. This is why this is so fascinating to me. And this is why I work with a psychotherapist who works on helping me connect to my body. I don't experience functional seizures, but I definitely disconnect versus being present. And this happens for me quite a lot emotionally, and I'm learning to connect and stay connected to my body emotionally. So, this person may have the functional seizures, and then of course, not only that person, but their parents and their friends and their family members are going to have some increased concern. Yeah, I think you should have some concern, increased concern and worry that this may occur again. And also, what is causing this? Is this a stroke? Is this a tumor? Like, those are big causes of seizures, right? And so this can really feed into a cycle until we can reconnect the experiences and decrease the level of concern that this is indeed actually not a tumor, but this is a real event that is occurring, and it occurs in many people, and it occurs because of this disconnect, and we're going to help you reconnect. It's so powerful. Oh, good question, Allison. We'll finish off with this one. I love this. What are some verbal phrases you would encourage clinicians to say to a patient during or after a seizure? I wish I had Chelsea on here because I feel like she's just the queen of doing this in the moment. Because I do think there are some things that are person specific, right? Depending on what that person needs. But if I'm meeting somebody for the first time, we're doing an evaluation, I know they have functional seizures, they experience a seizure, I would first say, Allison, I'm going to talk to them before and say, what do you need? What do you need from me? Because again, I want that person to experience some control, right? So not me being me on top of that person and influencing like, well, here's what I think you need, but what do you know that you need? If we can establish that beforehand, then I can come in and help be that. So a lot of times it's like, hey, I'm here with you. You're experiencing a functional seizure and we're going to be okay. I'm here with you. Right. And I understand what is happening. And if we've already explored some ways to stay connected, we might actually explore some of those things. So if that's adding some weight, like I know and I understand when you're experiencing a functional seizure, you feel outside of your body. We're going to try to come back in. In the past, when we've done it together, the weight really helped. So can we put weight right here on your shoulders? So permission and autonomy through that whole process. And those are things too that we don't only explore together in therapy, but it's like for the family, for the friends that might be with that person. These are things then that person can bring to anybody when they're experiencing that. In fact, we have somebody, really active woman, plays tennis, goes to the dog parks, and she experiences some of these, and she lets people know ahead of time, hey, I might experience this, and you might want to call 911, but I'm actually okay, and I will be okay. Just give it a couple of minutes, and I'll begin to recover. And she advocates for herself in that moment. And it's so powerful. It's so powerful. I'm going to come back to this one just one more time, because one of the things that I really love working with our OT and our psychologist is that working on some of the autonomic practices and bringing them, oh, I lost my picture of it. Okay. Well, you're going to remember that picture. But the autonomic practices, which are free for download, by the way, those are things that we can also use and say in the moment. Sherry says, too, have had to work hard with our hospital-based outpatient and not calling rapid response teams. Yes, because I mean, have you been there with the rapid response team? I know you have, Sherry. I know I've worked in the hospital. I've worked in hospital outpatient. And it is traumatizing and so scary. And, certainly if it's somebody's first seizure and you don't know, that might be the most appropriate response. But with a person who has a known functional seizure disorder, then you don't do that. That actually worsens that loop that I was just showing. It worsens it. And so, yeah, Sherry, there's so much education to happen there. Absolutely. And I love too that Bella said, great question, Bella. I'm so glad you're here as well. And Bella is another person with a functional neurologic disorder that has shared some of her story with us as well. You can see that on our Instagram page. But I just want to thank you, Allison. Thank you. Thank you for all the great questions. Lily, thank you for the great questions. Thank you to our Brain Bites community who has had so many great questions. I feel like we're going to have a part 2. There's so much to talk about with functional neurologic disorders and functional seizures. But here's the bottom line. You can recover. They can get better and they can be controlled and you can regain control. And as a PT, as an OT, you can help people regain control. So I just want to encourage you to keep learning and growing in this. Oh, Bella says she's 6 weeks seizure free. I didn't even know that because of Re+active. Bella, actually, because of you. Because of you and because of what you've done to heal yourself and stay connected to your body. So yes, Bella, we're celebrating with you. Thank you so much. And Gail, I see your question here, so I'm going to catch that for the next time because I do have to run. Thank you so much for joining me today for this awesome conversation, and we'll do it again. Catch me on Friday to our Facebook page to meet with Katie and hear her story as well. Thanks again, everyone. Have a great day.